Vermontijuana, and I'm telling you guys, elevate the state.
Online on Twitter, Vermontijuana writes to us.
So tonight's session is called Health Effects of Marijuana, Policy Strategies to Minimize Potential Adverse Health Impacts of Legalizing Marijuana, a topic that I'm sure you have been hearing a lot about, and we will be hearing a lot more about as the legislative session unfolds. Tonight we really want to share most importantly with you not only what we know, but how we know what we know and what a public health approach is. So one of the fundamental things that we believe in is a health and all policies approach. And that means we recognize that there are many policies and programs that are designed in one sector that end up having unanticipated consequences in another. So for those of you who are associated with UVM, you will remember the best intentions when they banned the bottle at UVM to minimize the amount of environmental waste. And what has happened, it has increased the consumption of sugary sweetened beverages. So that was a public health impact that was not considered. Why would it be necessarily when one is making a policy on banning refillable bottles? But had they taken a health and all policies approach, used a health impact assessment process, they might have been able to anticipate the unintended health consequence and in fact planned ahead for it, so that there was something that could be done to minimize negative health impacts and emphasize the positive. And that's what we're here about hoping to do tonight, is we take a data-driven decision-making process where we want to lead with science, use the best available data to inform policy decisions. So you may ask, does Vermont Public Health Association already have a policy on whether or not pot or marijuana or cannabis, however you choose to refer to it, if it should be legalized in Vermont? We do not have such a policy, because what we needed to do first was make sure that we were starting with the best available information upon which to make our decision. So we've invited you here to be part of our learning process and part of our deliberative process while we are figuring out what statements are going to be most important to us when we talk in this upcoming legislative session about how we make sure that if legislation moves forward, that it takes account of the potential health impacts of legalization, regulation, and taxation. Okay? So the purpose of tonight is to help us all understand and begin answering two main questions. The first is, what are the potential health impacts of legalizing marijuana use? So our first presenters are going to share with us the results of an assessment of potential health impacts in Vermont. It's a study that's being conducted currently at the Department of Health. And we have Shayla Livingston and John Searles who are here with us to share that. I'm going to pause for a second and give you their brief bios tonight, because today's agenda, as I said, is packed. And once I get off of talking, I'm going to turn it over to the presenters until the very end. So we're going to hold questions to the end. Both of our presenters have said they would wait. I thought it most important that you get their content first and questions at the end. So our first presenter is Shayla Livingston. Shayla was born and raised in Sharon, Vermont. She attended Smith College, where she received a bachelor's degree in government. She then received a master's in public health from UC Berkeley with a focus on maternal and child health. She began working for the Department of Health in June of 2012. She is an epidemiologist and an evaluator for our Division of Alcohol and Drug Abuse Programs. We also have John Searles, who will be the silent partner in tonight's presentation. But John has been Shayla's counterpart in the assessment process. And John is the Substance Abuse Research and Policy Analyst and chair of our state epidemiology work group for the Division of Alcohol and Drug Abuse Programs in the Department of Health. He has been on faculty at the University of California, Berkeley, the University of Pennsylvania, and the University of Vermont. He has co-edited 2 books, Children of Alcoholics and Alcohol in the Family, and published over 50 scientific articles in the substance abuse field. He has a doctorate in personality psychology from the University of California, Berkeley. So John and Shayla are going to share their results so far in progress of the assessment of potential health impacts of marijuana, and particularly within the Vermont context. The second key issue a question we're going to try to address in tonight's session is what lessons can be learned from tobacco policy. So there's been a lot of conversation about, are there ways in which we could legalize marijuana? If that is where we're going in Vermont, how do we know that we're doing it with the best protections in place for public health and to minimize any potential negative health impacts? And there are quite a few lessons to be learned both from alcohol and tobacco. Tonight we're going to hear specifically about tobacco from Carrie Cork. And Carrie is from the Public Health Law Center, the Tobacco Control Legal Consortium. She's a staff attorney at the Law Center for over 12 years, and she provides legal technical assistance on tobacco and other public health issues in public health professionals' organizations throughout the United States. She also oversees development and dissemination of publications and communications. She's published and presented on many tobacco and health law issues, and has been the principal investigator on both national and local tobacco law research grants. One of her recent projects was a paper researching lessons from tobacco control that can be applied to marijuana, which is why we invited Carrie to join us tonight. She has a bachelor's and master's degree in English literature from the University of Minnesota and a law degree from William Mitchell College of Law. So those are our presenters. We gave them a really high task, which was to try and cover a tremendous amount of ground in 25 minutes each. I know that they have practice to get through it, and so I appreciate if you wouldn't mind holding your questions until the very end, recognizing that this is our opportunity to learn. We will deliberate later. So right now, it's really about what do we need to know so that we have the best available data to us when we start our deliberations about what policy should be. So just putting that out there, and with that, I think I'm going to turn it over to Shayla, who is our first presenter.
Thank you very much.
Okay, thank you.
All right, thank you all very much for coming tonight. I'm going to try to get through this and be as clear as possible. So I'm going to talk about what a marijuana health impact assessment is in the state of Vermont and what the health impact assessment process looks like. And then I'm going to show you the results of our literature review and just review that, and then talk about what the next steps are for the group in this process. So the definition of a health impact assessment is a process to evaluate plans or policies based on their potential effects. And the potential is underlined because it's supposed to be an evaluation of something that has not happened yet. So marijuana regulation in Vermont is a very good example of that. Potential effects on the health of a population and the distribution of those effects within the population. So the distribution piece is very important because it's not about the health effect on one person, it's about the health effect on an entire population, and within that population, specific pockets that might be more or less affected depending on certain demographics or where they live, et cetera, et cetera. And critical here is that it is not a process about whether or not to complete a policy. So when this is all said and done and up online and everybody can read it, it will not be a statement that says the health impact assessment stakeholder group recommends regulating marijuana or not. Rather, what it will be is a document saying that if there is a decision to regulate marijuana in Vermont, here are the recommendations of this group for how to do it in a way that would best protect and enhance the health of the state. So there's a number of steps in this process. The first one is screening, and that's where you just decide whether or not to do a health impact assessment. That step in this case was taken by the health department leadership, and essentially they said, look, this is a policy that looks like it's moving in the legislature, and it's something that could potentially have a health impact on Vermonters, and so we'd like this process to move forward on this topic. The next step is scoping, and that's really where you decide to hone down your analysis and figure out what specifically you're going to look at. That happened with the stakeholder group, and the stakeholder group are individuals from all different sectors in Vermont, so schools and the medical dispensaries that we have in Vermont, and all different groups, and we tried to really get a variety of people, and the breadth is really important in that group, and it's been a great group. They've been very engaged, and they did the scoping process, and that was where they built a pathway diagram, and I'll show you that in a second. Next is the assessment, and that's the piece that we're on right now. So I'm not going to, unfortunately, tell you our recommendations tonight because we don't have them yet, but I will show you the beginning of the assessment process, and that's where we take all of the literature that we can, and we look at how it could be applied to Vermont data and statistics. Finally, it's the recommendations and reporting. That's where the stakeholders will make recommendations of how to either improve or enhance health benefits, potential health benefits of a policy, or try to negate any negative health impacts of a policy. So again, we will be hearing from Carrie tonight, and she has some lessons from how that did work, or could work better with tobacco. Reporting is just publishing the report and getting it out there and making sure folks know it's available. And then monitoring is a really critical piece of this process. We're going to make sure we actually track over time what happens if this policy does go through. This is the pathway diagram, and I acknowledge that this slide has got a lot on it. So the critical thing is the blue box at the left-hand side. That's where we're just saying this is the thing that's going to happen. So potentially marijuana will be regulated in the state. Then the green, the colors just denote sort of the next steps along the pathway towards a health effect. So these were all chosen by that broad stakeholder group. And you can see that in the beginning, it's like access or perception of risk. So it's like the very first things that might change. Notice that there's no up or down. So nothing in this says it's going to get better, it's going to get worse. It's just it could change or this thing might be impacted. So we then take this and use this to develop questions. And the questions are what we answer in our assessment. So that group developed the pathway, and then they developed questions. Here are the questions. The first one is, what would happen to the prevalence of marijuana use if Vermont regulated marijuana? So that's the key question, and I'll talk about why that's a really hard question to answer in a little bit. But that one is obviously necessary for the rest of the analysis. The next one is traffic safety. So this is a big one. It's getting a lot of attention, and they wanted to make sure to focus on that specifically. The third one is about mental health, and we do want to recognize the stakeholder group has been very clear that they do consider mental health a part of health, and that breaking it out like this is a little bit artificial. But we did it this way in order to be able to use the research and the statistics which do get broken out into mental health and physical health frequently. And along with mental health are psychosocial outcomes. So both of those are sort of this subset of mental health, I guess. Next is what might change in other substance use disorders and substance use disorder treatment. So that's really asking the question, if prevalence changes, what will happen with treatment and dependence in Vermont? What could change in academic outcomes? That's focused on youth, and particularly youth in school. So looking at those outcomes and research on academics. Emergency department and primary care, that's fairly straightforward. Just want to make sure we know whether or not that would go up or down, and what that might look like. And by the way, the primary care piece was added sort of at the end of the process, and it was an acknowledgement to the fact that Vermont tries to do a lot of preventive primary care work. And so we did want to at least look at that setting a little bit, even though the research there is actually thinner, turns out. And then finally, how does regulation affect youth substance use initiation and prevalence with adult-only substances? So this is really this piece that Carrie will talk about. What can we draw on from tobacco and alcohol, and what can we learn from that, and what might we kind of know or not quite know about changes that will happen for youth use based on those two substances. All right, so the literature review. So this is something that we'll present the most of tonight. The literature review was extensive. It was, we cast a very wide net, and I'll show you the results of that obviously, but we looked in PubMed and PsycInfo for anything that had marijuana or cannabis and health or youth or driving, or motor vehicle. There's also somewhere great. Let's drive in there. And so that gave us back, we ended up reading 180 articles between 6 people. And ideally in a literature review, you would have 2 people read each article and double rate. Because of the time and the staffing, we were not able to double rate, but we did have 6 different individuals doing it using the same criteria. And we did end up reading about 180 articles. We were looking for all, positive, negative, neutral, all the different types of effects that could happen. So this was not looking for just one piece or another. We were really just trying to see everything that's out there, read it and rate it, and summarize it. We did not include medical marijuana or decriminalization. And the reason for that is that both of those things are already legal in Vermont. I want to just say that that came out in the scoping process. So that was really a question of if the policy changes, it's not going to change decrim or medical because those things are already here. However, in the stakeholder group, it was brought up that there are certain conditions that are not covered right now with Vermont's medical marijuana laws. And therefore, that those should be considered when we're looking at a potential health change from regulation in Vermont. So we did do a much briefer process where we looked at 3 comprehensive systematic reviews of the literature on medical marijuana. So that was different than the primary literature review. It was much more focused and it was much more targeted to make sure that we did include that in the process. The tables that I'm about to show you have 3 columns. There's the health indicator, there's the direction of the evidence, and there's the strength of that evidence. The strength of the evidence is not the strength of association. So I'm going to use a silly example. If you walk out into a field during a lightning storm, your odds of getting hit by lightning go up dramatically. But overall, your odds of getting hit by lightning are still very, very, very low. So these tables do not show you that absolute increase in odds. And there's a couple reasons for that. One is we just haven't quite gotten there yet. The other reason is that some of these estimates are not precise, so there's large ranges. And we will try to take that into consideration when we do the calculations, but that's not in the table. So when you see that strength column, that's just the strength of the evidence. So that's how certain we are that it's actually a real difference or a real change in the literature. So here is our rating scheme, and we borrowed this from our friends in Washington. They were very nice to share it with us. We've got not well researched, so that's 1 star, a fair amount of evidence, strong evidence, and very strong evidence. And I'm actually just going to read you what those were. Not well researched is the lit review yielded few, if any, studies. A fair amount of research is the literature review yielded several studies supporting association, but a large body of evidence was not established. Strong evidence, the lit review yielded a large body of evidence on the relationship, but the body of evidence did contain some contradictory findings. And very strong evidence is the literature review yielded a very large body of robust evidence supporting the association with few, if any, contradictions. So a really important thing here, and I fall victim to it too, even though I'm an epidemiologist, is that you'll sometimes see in the news, a new study's out, and it says X. And it's exciting, and you read it, and then unfortunately sometimes we believe it immediately. And what we tried to do here was look at all of the different studies. So something that has strong evidence or very strong evidence is corroborated by many studies or multiple studies. It's not just one. So that's a really important piece. The other really important piece is longitudinal data, so causation versus association. So whether or not we had a study that actually was over time with a population that looks at least a little bit like Vermont. And if we had that, then that's easier. It's a stronger body of evidence than something that's just one point in time when you might not be able to tell what came first. A great example of that is in the back. There's a data brief on marijuana use in high school, and it's got a table in the back with the association of marijuana use with a bunch of other indicators. And that table does not say that marijuana use causes those other indicators. It just says that they are associated with them. Okay, so this is our first table. So I'm going to group them a little bit so that I don't bore you all to tears. So mental health was that first big grouping. As you can see, all of the directions were worse. So this is for use. Note that it's not for legalization or regulation. So this is not about if we regulate, then all these things will get worse. It's if somebody uses, if the population uses, then overall the health outcome on the left-hand side there will get worse. Psychotic symptoms, depression, schizophrenia, anxiety, brain function, and psychosocial functioning. The ones that have the most evidence are psychosocial functioning and psychotic symptoms. Psychotic symptoms and psychosis is a very good example of an indicator that is rare. So when it's saying it's worse, we're not saying that everybody who smokes or uses marijuana is going to suddenly develop psychotic symptoms. It's just that if you do use marijuana, you are more likely to do that. And again, the next step of analysis that we haven't gotten to yet will be exactly how many people that might or might not be. Injury, motor vehicle accidents, they are worse, both fatal and non-fatal, and there's very strong evidence to support that. Skiing safety, there's no research. I was just on the phone today with somebody in Colorado, and they said, yeah, we'd really like that too. And I said, okay, similar tourist industry, similar problem, but we don't have any research there yet. Next body is respiratory, so we've got short-term airflow, long-term airflow, cancer, and chronic bronchitis. Difference between short-term airflow and long-term airflow is just short-term is right after you use or smoke in this case, and long-term is over time. So you can see that for short-term airflow, it is better, and there's actually very good evidence for that. So this has been used actually for a long time in asthma, and not suggesting that you do that, but that it does actually dilate the bronchial cavity in some way. Long-term airflow gets worse, however, so if it's done over time, it does do damage. Cancer, it's very unclear. So this is for respiratory cancer, so lung cancer being the obvious one. There is not enough evidence, essentially, to say one way or another on that topic yet. Chronic bronchitis is worse, and the evidence there is fairly strong. Physical health, non-lung or non-respiratory cancer is also unclear, so going both ways. And I want to be very clear here about what I mean by cancer in both these cases. Many individuals use medical marijuana in order to treat the symptoms of cancer or the symptoms of cancer treatment. That is not what we're talking about here. We're talking about whether or not using marijuana could lead to getting cancer. So that's what I mean when I say that it's not clear here its relationship to cancer. So in both cases, there is research on both sides, and there's not very much on both sides. Stroke and heart attack is worse, but it's not very much evidence, so not something we're gonna hang our hat on. That's the 2 stars, but not quite there yet. And then pregnancy, we do know quite a bit about reproductive health in pregnancy, and the Academy of Obstetricians and Gynecologists just came out with a statement around use in pregnancy and saying that women who are pregnant should not use for the sake of both their fetus and the pregnancy outcome. Impact of marijuana use on youth. So we broke out youth here, again, because in health impact, we want to try to look at separate populations, and obviously youth are a different type of population than adults in the case of marijuana use. Future dependence and academic performance are both worse, and there is very strong evidence to support that. Substance abuse generally, dual use is maybe worse, but we don't know that yet. And one of the big questions is whether or not folks who use marijuana use less alcohol. And it's sort of all over the map right now. We don't have anything strong on that quite yet. Treatment and future use, there's not enough data out there at all. And then dependence on marijuana is worse. So we do know that 1 in 10 people who use marijuana do become dependent on it. So that one's pretty solid. So this next table is actually looking at regulation on marijuana use. So that left-hand column is the impact of marijuana regulation on marijuana use. And we just wanted to break that out for youth because, again, they are an important population. Child poisoning or child ingestion, over-ingestion. There is some very preliminary data out of Colorado that suggests that it is getting worse there, but that is also not conclusive and not something that we can say for sure yet. There's youth access. We know that youth access will probably be greater. So worse is a funny term in this case because we think that youth, based on the research, youth will probably gain more access to marijuana if it is regulated in the state. And youth use, there's too little research and there's too little data. So we can't say much about that quite yet. And by the way, when I say we can't say much about that for youth use, it could be that that will go down, or it could be that that will go up, or it could be that it would stay the same. Going to breeze through this very quickly, because again, this is not the focus, but this is the slide about medical marijuana. And the symptoms on the left, you will see one of the ones that is not legal in Vermont, but does have evidence, is chronic pain that is not severe. And so that is something that we will take into consideration potentially in this process. All right, so next, once we have all the literature, and again, it's sort of a constant thing. There's the government reports that we take into consideration, and we did follow a lot of the references from the articles that we found. So at some point, I have to cut John Searles off completely and tell the stakeholder group that we have to stop, but they keep sending us stuff, and we keep finding more. But the next step after that, and what we're starting on right now, is trying to take Vermont data and actually estimate the numbers from the literature and from what we know from the science. There are some really, really big question marks in doing that, and the critical unknowns are the age at which consumers begin using. So will that go down? Will that go up? We don't know that. The number of consumers, that's just the prevalence. That's probably the number you think of the most if you're thinking about it. The number of days each consumer uses, the number of times a day they use, and then the potency of each dose. So all of those are very variable, and we don't have them pinned down. I do want to just pause on potency of dose for a second. There's debate about that, and we think that probably the market in Vermont and in the US was about 8% THC in 2010 on average. So when you went to buy marijuana on the black market, we think that it was about 8%. There is debate about that. Maybe it was 4%, maybe it was 6%. So that number is roughly between 4% and 8%. Now in Colorado, we have hard data on what the potency is and the THC content is on the marijuana that's being sold there legally, and that is 17%. So regardless of what it was now, it is much higher there than we think it could be here at the moment. And so the big thing there is that when you're looking at public health and you're looking at population health, you want to look at the dosage or the exposure time and the dose amount, and that potency could really change the picture. On the other hand, it could be that consumers realize that it's more potent and therefore use less of it. And that is a possibility, and in Colorado, they hopefully will begin to explore that soon. How are we going to start calculating numbers? So the RAND Corporation did do a report for the governor's office, and that was released earlier this year. So we are going to try to use their work and not redo it all. So they have an estimation of a 50% increase of use after or under what they call a legalization structure. There's a big range there. They give you a really wide range of how much use could increase, but 50% is the mid-range, and that's the one that they use. So we'll probably end up using that, and we'll list all of the different crazy limitations that go along with that. But the important thing there is to try to at least produce an estimate that then can be considered when policymakers and decision makers are trying to think about what else to put into the policy and what other ideas or regulations or aspects that they want to address in that policy. The second one is a study for monitoring the future, which is a national study. It's very well known and well respected. So they asked students what they would do if marijuana were legalized, and they found a 5.6% overall increase in senior lifetime marijuana use. Obviously, that's a hypothetical question asked of 12th graders. So it's not exactly rock solid, but we're going to start with that. We'll probably do some estimations around that. We might try to find other pieces that could work. But that's an option. All right, so we're going to use our data and try to apply the literature to our data. I'm just telling you I'm running out of time, so I'm going to speed through these. And I wanted to show you a little bit of our data. So this is the National Survey on Drug Use and Health. This is done every year in Vermont and in all other states across the nation. You can see that from 2012 to 2013, there was a drop in use, past 30-day use among 18 to 25-year-olds. And that from 2003 to 2013, there's been a slight increase in use among those who are 26 and older. Vermont does have higher rates than the rest of the country. So you can see this is past year marijuana use. This is again by age group. So on the left you have 18 to 25-year-olds, and on the right you have 26 plus. And the green is Vermont, and the black is the US. So you can see that Vermont has a substantially higher past year marijuana use rate than the United States. Of note, perception of harm is an interesting measure. We do ask individuals that just to see what they think the risk is to their own health. And you can see that 12 to 17-year-olds, 21% said that they thought there was great risk to their health, smoking marijuana at least once a month. 10% of 18 to 25-year-olds, and 25% of 26 plus. If I'm just going to flip back for you to this slide, you can see that the perception of risk is related to the use rate. So you can see that 18 to 25-year-olds have a much higher use rate than those 26 plus. Here's high school students. This is all high school students, 9 through 12 in Vermont. This is from the Youth Risk Behavior Survey. You can see that from 2003 to 2013, there was a slight decrease, and that decrease happened between 2003 and 2005. And since then, it's been very flat. Just to give you a reference point, 24% is 1 in 4 students, and this is past 30-day marijuana use. So a lot of our students are already using marijuana. And they're using it a lot. So this slide shows you how many times they used in the past 30 days. So about a third used 1 to 2 times. A little more than a third used between 3 and 19 times. And about a little less than a third used 20 or more times. And 20 or more is what we consider daily use, approximately daily use. So we've got about not quite a third of our students who are reporting, and this is of those who said they used marijuana in the past 30 days, about 30% of them, 31% of them are using it daily. We can look at dual use. We can't look at use at the exact same time, so this isn't like, hey, when you were at that party, did you use both pot and alcohol at the same time? This question rather are 2 different questions that we put together. But it does show that those students who use marijuana are more likely to binge drink than those who don't. And remember, that is association, not causation there. Sorry, we sped through that, but I just want to get to next steps. So we are going to take that data, and we're going to take that lit review, and we're going to try to combine them and see if we can come up with numbers for what might or might not happen in Vermont. We will try to list and be very clear and transparent with all of our limitations or assumptions. The stakeholder group will then take that analysis and make their recommendations for what might or might not go into a marijuana regulation law in Vermont. And we'll publish the report and let you all know, and then we'll monitor the results.
I want to thank Shayla for cruising through a tremendous amount of material for us, and while she gets us set up, remember we tasked her with helping us to understand what the potential health impacts might be of marijuana use, and then our next speaker is really going to help us try and figure out what can be learned from tobacco legislation. That's okay. Through tobacco legislation.
I appreciate you all coming here tonight. I'm sorry I wasn't able to be with you in person. It's been on my bucket list forever to visit Vermont, particularly in the fall, but unfortunately we weren't able to make it work today. I have to admit, I've given webinars before, but this is the first time I've given a webinar remotely to an auditorium of people. And honestly, it's a little daunting to be speaking and not seeing your faces. It's also a bit daunting because I'm a tobacco control attorney and by no stretch of the imagination an expert on marijuana regulation. Okay, so that's my disclaimer. What I'm going to be focusing on in this presentation are similar issues that policymakers face when regulating tobacco products and marijuana products, as well as lessons that we've learned in the tobacco control realm that state and local governments might want to consider when developing marijuana regulations. Okay, before I get started, I just want to say a few words about my organization, the Tobacco Control Legal Consortium, which is a program of the Public Health Law Center. The consortium is a nonprofit national network of tobacco control attorneys based in St. Paul, Minnesota, which serves public health advocates and professionals around the country. We support tobacco control policy change by providing free legal research, analysis, and interpretation, policy development, litigation support, educational resources, and training such as this presentation. So why is a tobacco control attorney presenting on marijuana? Well, as I said, we provide legal technical assistance on tobacco control issues to states and local communities throughout the U.S. And one of the hot topics du jour is the legalization of marijuana. Over the last few years, we found ourselves fielding a growing number of questions about marijuana. And I'm talking here about the consortium, as well as our colleagues at the Network for Public Health Law, which handles questions from state health departments on a wide range of public health issues. Often these questions are related to smoking marijuana in public places, workplaces, private residences, or similar issues. And as we've been looking at the growth of marijuana legislation, we've seen parallels in tobacco control legislation, and also similar challenges in e-cigarette legislation. Of course, with recreational marijuana and to a large extent e-cigarette products, regulatory systems are in their infancy. As public health professionals, we base policies on evidence-based data, and we have a tremendous amount of scientific data to inform tobacco control strategies, going back more than 50 years to the first Surgeon General's report. Not only do we have a wealth of research on the health impact of tobacco use and the consequences of exposure to secondhand smoke, but on the effectiveness of smoke-free, pricing, advertising and marketing, point of sale, and youth access policies on user consumption. When it comes to marijuana, particularly regarding the health consequences of marijuana use and the most effective public health policies to regulate this product, we're largely learning as we go. Okay, so here's an overview of what I'll be covering today. I'll take a brief look at the national landscape of marijuana regulation and some of the public health and safety issues we need to be concerned about, which Shayla has already addressed, but which tie directly into my next topic: policy options for regulating tobacco products that could be adapted for regulating marijuana. And finally, I'll touch on a few lessons that we learned in tobacco control that might be helpful to keep in mind in regulating marijuana. Because marijuana regulatory systems in each state are so jurisdiction specific, what I'm going to do here is provide a general overview of concerns that any state or local community might want to consider looking at this issue through a tobacco control prism. Just as quick background, as I'm sure you all know, 23 states and Guam have medical marijuana programs, each with its own list of qualifying conditions. Only 5 jurisdictions permit recreational marijuana. At least 10 other states are considering legalizing marijuana by 2016. Several are attempting to put recreational marijuana on state ballots next year. And in Ohio, there's a statewide initiative on the November ballot to amend the state constitution to allow the use, possession, cultivation, and retail sale of recreational marijuana. By 2020, according to industry estimates, there could be as many as 18 states where recreational marijuana is legal. According to industry analysts, legal marijuana is the fastest growing industry in the U.S. This development is particularly interesting given marijuana's legal status. As you know, marijuana is a mind-altering drug. It contains more than 300 active chemicals, including THC, the ingredient that produces marijuana's psychoactive effect. Because of this, even though many researchers and scientists have found that marijuana can be effective in treating a wide range of illnesses and symptoms, under the Federal Controlled Substances Act of 1970, marijuana is still categorized as a Schedule I drug, that is a drug with high potential for abuse, with no currently accepted medical use and treatment in the U.S. Thus, it remains a federal offense to cultivate, manufacture, distribute, sell, purchase, possess, or use marijuana. Although it would appear that federal law is in conflict with any state law that allows marijuana to be used for either recreational or medicinal purposes, this area of law remains unsettled. The Department of Justice has announced that the current administration will not prosecute individuals or organizations engaged in marijuana activities that are conducted in clear compliance with state and local narcotic laws that permit and regulate these activities. This tolerant policy could, however, change in any future administration. And I suppose that's a good thing, given the number of states that exempt qualified users of medical marijuana from penalties imposed under state law, and the number that have decriminalized possession of small amounts of marijuana. State laws permitting the use of medical or recreational marijuana vary greatly in their scope and implementation strategies. And state and local governments continue to debate the safety, efficacy, and at times legality of measures taken to implement these laws. The laws are frequently confusing. Even the terms referring to marijuana decriminalization and legalization are often misunderstood. A state decriminalizes conduct when criminal penalties are removed, but civil penalties remain. Massachusetts, for instance, removes criminal penalties for possession of small amounts of marijuana, but retains civil penalties. A state legalizes conduct when an individual who engages in this conduct is not subject to any state penalty. Washington and Colorado, for example, have removed all state-imposed penalties on qualified marijuana activities, such as production, distribution, and possession. Also, states vary a great deal in how much regulatory authority is delegated to local jurisdictions to regulate marijuana. I'm not going to get into this at all, other than to note some parallels with tobacco control in the way some states may partially delegate authority to local governments. A state, for example, might control all aspects of how medical marijuana growers or dispensaries function, but still allow local governments the legal authority to pass zoning and licensing ordinances that prevent marijuana dispensaries from operating in their communities. At the same time, this delegation of authority illustrates a key difference between marijuana and tobacco regulation. Since marijuana is illegal under federal law, any regulation that allows for the use of the product needs to be developed and implemented at the state or local level. In tobacco, however, certain rules of tobacco regulation, such as creating product standards, are exclusively in the federal government's domain. As we know, many medical professionals and researchers, including the Institute of Medicine, recognize that marijuana, primarily THC, can be effective in treating a wide range of illnesses, symptoms, and conditions. At the same time, the Institute also acknowledges that smoked marijuana delivers harmful substances. Despite evidence of the benefits of medical marijuana for certain conditions, underlying public health concerns remain about its health risk. Obviously, the use of tobacco has far more adverse health effects than the use of marijuana. Still, marijuana is not a risk-free drug. Research has shown that frequent marijuana use can impair learning, interfere with memory, perception, and judgment, and damage the heart, lungs, and immature systems. These risks are magnified for people who start using marijuana at a young age, and some of the effects are irreversible. Marijuana has also been shown to pose serious health risks when used by pregnant women, since THC crosses the placental barrier and accumulates in fetal tissues. Also, because marijuana impairs judgment and motor coordination and slows reaction time, a driver high on marijuana has an increased chance of being involved in and being responsible for an accident. Finally, marijuana smokers may risk exposing others to secondhand smoke, which can be a health hazard. Some researchers have found that marijuana smoke contains significantly higher levels of toxic compounds, including ammonia and hydrogen cyanide, than tobacco smoke, and may pose similar health risks. Given these health concerns, most regulatory schemes for marijuana focus on limiting the overall consumption of recreational marijuana and restricting youth access. These public health goals are similar to tobacco control goals. So let's look at some other similarities between these products. Both, of course, can be consumed in a variety of ways. Marijuana can be smoked using a rolled cigarette, a joint, a cigar, cigarillo, a blunt, or a pipe, bong. Cannabis-derived hash oil with THC can be consumed through vaporizers similar to those used in e-cigarettes, and we'll discuss that more in a moment. In addition, it can be consumed through food, edibles, beverages, and pills, and tobacco, as we know, can be consumed orally as snuff and chewing tobacco. Also, both products have a significant appeal to youth, are widely trafficked, and provide or could provide economic revenue to states and local communities through taxation. Finally, some tobacco control advocates are concerned that a rapidly growing marijuana industry may come to resemble the tobacco industry by encouraging increased investment by major corporations. I've read estimates that the legal marijuana market may be worth well over $10 billion by 2019. Okay, so in addition to the similarities I've just mentioned between tobacco and marijuana products, there are also similarities in some of the policies that local and state governments are considering or implementing to regulate marijuana. For tobacco control folks, I'm sure this list looks pretty familiar. Each of these policies for regulating tobacco products could be adapted for regulating marijuana. So let's look first at regulating product use. In addition to concern about the possible adverse health impact of secondhand smoke, some members of the public health community are troubled by the social impact, particularly on the young, of normalizing the smoking of marijuana in public. Although states with marijuana laws generally prohibit the smoking of marijuana in public places and workplaces, the growing acceptance of recreational marijuana use makes it important to have strong policies prohibiting its use in public places. Under federal law, the use of marijuana in public places is prohibited. Although state laws usually include prohibitions against smoking of marijuana where smoking tobacco products is prohibited, state and local smoke-free laws should be reviewed for their comprehensiveness and, if necessary, expanded to include language prohibiting smoking marijuana in public places and workplaces. Now, of course, there are e-cigarettes, which have become quite popular with youth. According to recent reports from the CDC and FDA, approximately 1.5 million U.S. middle and high school students used flavored e-cigarettes in the past 30 days. Also, a recent survey of e-cigarette use by Connecticut teens found that nearly 1 in 5 high school students who admit to using an electronic smoking device have also used it to vaporize cannabis or byproducts like hash oil and wax infused with THC. Teens can use e-cigarettes and similar devices, such as vape pens, covertly with little risk of detection, because when these items are used to vape hash oil or similar substances, they typically don't emit the odor of marijuana. And I won't even get into dabbing, which is essentially freebasing potent, highly processed hash oil, a process using volatile chemicals, a highly concentrated product, and as Slade put it, incredibly stoned kids with blowtorches, and which, according to Rolling Stone, can get you cosmically baked. Dabbing aside, electronic delivery devices are becoming a product of choice for many kids interested in vaporized pharmaceuticals. State and local governments may thus have a dual public health purpose in prohibiting public use of e-cigarettes. One, to prevent enforcement problems stemming from confusion as to whether an individual is using an e-cigarette or a conventional cigarette, and two, to prevent the surreptitious public consumption of marijuana or other drugs through an electronic smoking device. Also, as with the rise of vaping, hookah lounges, and cigar bars, some states have seen an increase in private marijuana, cannabis, or pot clubs to circumvent public use restrictions, even though many of these establishments may not technically be exempt from laws that prohibit the use of these products in public settings. These are familiar tactics to those of us in the tobacco control world. Many states allow employers to prohibit all employee use of tobacco products and drugs, such as marijuana, in an effort to develop a healthier workforce. Under the Occupational Safety and Health Administration Act, employers have a general duty to provide a safe workplace. Employees who use marijuana at work or off-site at break times could be considered a workplace hazard if their use poses a danger to other workers. One challenge to such policies is that under the Americans with Disabilities Act, an employer is required to make a reasonable accommodation to a qualified applicant or employee with a known disability, so the applicant or employee can perform a particular job. However, federal law doesn't recognize disabilities in the context of medically approved marijuana use, even if this use is approved by a state. So this is a complicated and evolving area of law. Because marijuana laws are so jurisdiction specific, you should check with local counsel with questions in this area. As I mentioned earlier, cannabis users who drive while under the influence could pose a public safety issue because their motor coordination may be impaired. This doesn't include just driving, but operating any kind of machinery that needs quick reflexes. Many states with marijuana laws prohibit driving while under the influence. Determining THC impairment, however, can be difficult because marijuana doesn't take effect immediately and because the level of intoxication depends on the type of marijuana product smoked, vaped, or otherwise ingested, as well as one's tolerance for the product. So someone could consume a product and then experience its effect more than an hour later when driving. Research is ongoing to identify the amount of THC concentration in the blood that indicates impairment and the type of test that could determine THC intoxication. Again, this is a tricky area and different states are addressing it differently. Secondhand smoke, whether from tobacco or marijuana, spreads through multi-unit dwellings, including the walls and floors. This smoke infiltration can damage the health of other residents and increase the costs of maintaining the apartments. Multi-unit residential property owners have the legal authority to make their property smoke-free, which includes prohibiting the smoking of marijuana in individual units and common areas, even in jurisdictions in which the use of medical and/or recreational marijuana is permitted by state law. This applies to public housing authorities and owners of other subsidized housing. Also, allowing smoking of marijuana on the premises could generate resident complaints due to drifting smoke, result in false advertising complaints, and even lead to Fair Housing Act complaints or lawsuits. Then there's youth access. Just as adolescents who use tobacco tend to become addicted to nicotine, research shows that young people who frequently use marijuana can also find themselves addicted. And studies show that youth are particularly susceptible to adverse health impacts of repeated high-dosage marijuana use, including the risk of mental health problems. As with the tobacco industry, which continues to develop new non-cigarette tobacco products, marijuana growers and manufacturers continue to invent new ways in which users can ingest this drug other than by smoking it. For example, there are capsules, vaporization, edibles such as brownies and canna butter, liquids such as tea, and a rise in products that appeal to youth, such as THC-infused chocolate bars, peanut butter cups, hard candies, and lollipops. And just as there has been a growing number of poisonings attributed to the consumption of candy-flavored nicotine juice, there's also been a rise in poisonings attributed to the consumption of kid-friendly marijuana products, such as cookies, chocolate bars, and brownies. Tobacco policy experts have attempted to reduce youth consumption in several ways, and many of these same strategies can be used to limit youth access to marijuana. For example, most tobacco and marijuana users begin using these products in their teens. As a result, a growing number of states and localities are raising the minimum legal sales age for tobacco products to 21. Similar policies could be set for recreational marijuana users, including specific processes for verifying age. Of course, medical marijuana is often allowed for use by those under the age of 21, with many states issuing user identification cards and maintaining user registries. Also, a large number of states are now requiring that e-nicotine liquid be sold in child-resistant packaging and be clearly labeled. Some supposedly nicotine-free products, for instance, have been tested and shown to contain nicotine. Similar safety and disclosure policies could apply to marijuana products. And just an aside, one of our colleagues at the Network for Public Health Law pointed out recently that an emerging concern in marijuana regulation is the use of pesticides in marijuana cultivation, since the chemicals can remain part of the product when used by consumers. So we need to ensure that marijuana plants are monitored and tested for pesticides, mold, and other impurities. The level of required testing for both safety and potency varies among the states. Now, from a public health perspective, quality control is essential. And then there's licensing. As they do with tobacco retailers, state and local governments have an interest in controlling the number, location, concentration, density, and types of marijuana establishments. For example, cultivators, manufacturers, and retailers in each community. License suspension or revocation, as well as monetary fines, are effective enforcement mechanism. State marijuana laws vary in how much authority localities have to license or regulate marijuana retailers. What's important to keep in mind is that marijuana retailers or dispensaries seeking licensure need to meet jurisdiction-specific licensing requirements, such as how far they must be located from schools, parks, playgrounds, or similar locations frequented by youth, and restrictions on the types of outlets that can sell marijuana products. State and local governments could also consider adopting licensing policies to limit point-of-sale advertising of marijuana products, such as restricting the placement of ads in certain store locations and restricting product displays. Keep in mind, though, that advertising restrictions at the point of sale are likely to face legal challenges on First Amendment grounds, so they'll need to be drafted carefully to withstand legal scrutiny. As with tobacco, one of the most effective ways to curb marijuana use is to raise the price. Levying a tax on marijuana products could lower its use among price-sensitive consumers, especially youth, while generating revenue that could then be used to reduce related healthcare costs and health disparities. Every state has its own tax code and system for collecting taxes for products such as tobacco. Many states also have set up systems for taxing marijuana, and a few have become money makers. For example, this August alone, Colorado collected $13 million in taxes, licenses, and fees from recreational and medical marijuana sales. That's $13 million in 1 month. As with tobacco products and increasingly electronic smoking devices, every jurisdiction is different. Tax rates and licensing fees vary among states. Much depends on which products or parts of products are taxed. With e-cigarettes, for example, policymakers look at the different e-cigarette components, such as the consumable material or e-juice and other parts of the device necessary for consumption. Another critical consideration is how to determine the base, such as price or weight, for any tax. Marijuana, for instance, could be taxed on its sales value. An ad valorem tax contains an automatic inflation adjustment since it rises as the cost of the product increases. Other options would be to tax on the gross weight of marijuana produced or sold or per unit of THC, but both these options depend on accurate, reliable testing procedures. I'm in no way an expert on taxation and would advise those considering this option to seek input from financial and enforcement specialists at the state level. In addition to imposing taxes, states and local governments with the requisite regulatory authority could prohibit discount and packaging practices by marijuana retailers and enact price floors, that is, minimum prices for certain products. State and local governments could also increase fines and penalties for marijuana tax evasion and for violations of all other marijuana product-related state laws, and enhance surveillance to prevent marijuana smuggling and tax evasion. Finally, there's the option of restricting the advertising and marketing of marijuana to limit interest in recreational products among minors and prevent any rise in drug abuse that may accompany greater availability. The tobacco industry spends over $9 billion a year advertising and promoting its products, and over 90% of that is targeted at advertising, price promotions and discounts, payments for prominent tobacco product displays, and other marketing tactics at the retail level. As a result, restricting tobacco advertising has long been a key tobacco control strategy. Here are some of the most common strategies for restricting retail tobacco advertising and marketing. Similar policies could be adapted for marijuana products in retail settings. Until fairly recently, states haven't seen dramatic increases in marijuana advertising, at least in the mass media, in part because those that have legalized the sale of recreational marijuana have also restricted its advertising. While marijuana isn't subject to the same constraints on advertising as tobacco due to the tobacco settlements, the advertising of marijuana, even in states where the advertising is legal, remains a gray area of law. Much of the mainstream media market has been reluctant to market cannabis, medical or recreational. However, that appears to be changing. In August 2014, the New York Times ran its first full-page ad promoting a marijuana company. It was a significant media event because of the newspaper's influence. As more states legalize the use of marijuana and as sales revenue increases, the need for effective restrictions on the way marijuana is advertised and marketed will only grow. Last week, 2 of my colleagues were at a conference in Oregon where the recreational marijuana law recently took effect, and they were pretty astonished at the number of people in Portland who were toking in public. They said it was hard to walk downtown and not see groups of people smoking pot in the open. They both said they saw advertising like this throughout the city on vehicles, storefronts, and billboards. Here's just one of the billboards they saw. It's touting a 24-hour cannabis dispensary, Jolly Greens, free cannabis lozenges, very patriotic, as you can see. And I've also heard of aerial banners promoting pot in planes over Seattle Hempfest. At any rate, I think the issue of restricting this type of advertising is definitely on the table. Obviously, mass media advertising is seen by everyone, including kids. Interestingly, Uruguay passed a law legalizing marijuana in 2013, but it bans all marijuana advertising and promotional activities. Yet, at the same time, Uruguay's law expressly allows marijuana products to be sold in pharmacies, which is a bit ironic from a tobacco control perspective, given that a growing number of pharmacies across the U.S. are now banning tobacco products from their shelves. Okay, so what are some of the takeaway tobacco control lessons from marijuana regulation? A great deal depends on the government's regulatory goals, since this is such a multifaceted issue. Here are just a few general guidelines that meet key public health objectives and apply to both tobacco and marijuana. Focus on restricting youth access and use, public use, especially when driving or in the workforce, and marketing advertising tactics. Draw on an interdisciplinary team to help draft policy, including experts in substance abuse, land use, licensing, taxation, public health, and of course law, particularly public health law. Craft policies that have concise definitions, robust enforcement options, a reasonable penalty and appeals process, and a well-planned implementation process. If marijuana smoking is included in smoke-free policies, be explicit about where it is prohibited. Use tobacco and alcohol policies for guidance and monitor situations in those jurisdictions that are also grappling with marijuana legalization. But keep in mind that this is a growing industry and each jurisdiction has different regulatory systems and administrative structures to consider. This is a new and evolving regulatory area, and the only way to stay ahead of the curve is to remain vigilant, stay informed, and above all, be flexible. Thank you very much.
Thank you all for staying with us. It was a lot of information to absorb. As we said, our goal tonight was to try and begin fleshing out the areas of knowledge and the research base that we needed to draw upon as we enter into our policy deliberations. So the first being, really, what do we know about the potential health impacts of marijuana use? And secondarily, are there any lessons that can be learned and adapted from what we have seen over many, many years of trying to regulate access and use of tobacco products? So those are our two presenters. I thank you very much. We do have some time for questions if people would like.
Okay, so my question for Carrie is, given that in the case of tobacco, part of what gives the state standing to restrict advertising is the master settlement agreement, so it's through a punishment If she could say a little bit more about where the standing to restrict advertising with marijuana would be, since it's new, we're not punishing them.
There is no master settlement agreement, as you know, with marijuana. There would be no restrictions. There will be no problem with the states and local communities enforcing their own regulations and coming up with their own marketing and advertising restrictions. There's no federal requirement that these products not be marketed.
Okay, I hope that was intelligible.
Yeah, my name is Eli Harrington, and my question is about e-cigarettes and vaporizers. Seen a huge rise in their use, and know they're used a lot in cannabis, obviously, so wondering what tobacco has learned in its failure to prevent this explosion of vaporizers that maybe cannabis can learn from.
We're waiting for the Food and Drug Administration to pass a deeming regulation that will regulate e-cigarettes. And once that happens, we'll see how far they go in regulating e-cigarettes. We're learning more and more about the popularity of marijuana and vaporizing pharmaceuticals in these devices. And it's a growing concern, particularly given the popularity among young students and youth. So we're learning every week. Our organization, more than half of the requests for legal technical assistance we get today are, more than half of these requests are related to e-cigarettes. And many states around the country are implementing pretty stringent regulations.
Sure, thank you.
Controlling their use.
Just a quick follow-up, I guess, specifically about the marketing to children with those products. Is that a specific focus? I know there's fruit, bubblegum, hookah, vape pens that you can have, and I heard a lot of talk about, infused marijuana products, but wonder sort of what you're learning in that tobacco space and how that might influence, what is actually being learned, not what might be learned when the FDA is, in the future, what's being learned anecdotally.
Are you muted on your end?
It appears we're not going to get a response from Carrie right now, but we'll follow up with you. That's fine, Shayla.
Okay, so
Sorry.
what I'm going to do.
Okay, so what I think I'm going to do is turn over the questions to Shayla now. And so, if you remember, Shayla was our primary staff person at the Department of Health, working with John Searles to bring together stakeholders. So they brought together a group of folks representing education, substance abuse, economic development, what else? The Cannabis Collaborative. Really a broad range of folks who are really looking to see what they need to know about the potential health impacts of legalizing marijuana, and then therefore what do we want to pay attention to as conversations move forward around legalization, so that we're sure that we have anticipated to the best we can what the potential negative health impacts might be, what some of the positive ones might be, and ensure that our policies have those in mind so that we can protect the health and improve the health of Vermonters. So Shayla was the one who's done the primary research. Were there any questions about either the process that we're using for the health impact assessment or any of the key findings that they have so far, knowing that they're not at the recommendation stage yet? I'm bringing this forward so someone else can ask a question.
This is just a technical question. On the part of the presentation when you looked at the effect of use on various areas, did you have a definition of use that you could share? Thank you.
So that's a great question. That is among the problems with the literature that we have now. So the biggest issue, that list of limitations, and I think I could pull it up again, essentially exposure. And what you're asking is how do you determine exposure in marijuana studies? And the issue mainly here is that exposure depends on how frequently you're using it, how many days you're using it, and then the actual potency of the method and the type of marijuana you're using. So you heard Carrie talk a little bit about the different ways that it can be consumed, and a lot of the studies we think are mostly based on smoking marijuana, because again, the really good studies started a while ago, and so they are based on historical information and historical circumstance. But we don't know that, and oftentimes surveys and studies just ask how often did you use, how many times did you use, and not did you eat it, did you smoke it, did you vape it, what was the THC content. So those are all pieces in terms of the use question that are really important and that we don't necessarily have nailed down in the research and in the literature. So yeah, basically exposure and level of exposure.
Thanks. I have a question. I'm not sure if it would be best for you or for the second presenter, but around revenue that's generated, I know she referred to how much Colorado was bringing in, and I don't know if it's tied at all to your recommendations that you'll be making at the end of how much revenue and where that will be steered towards, if you will be commenting on that at all.
So the RAND report did focus a lot on what the potential economic gains could be for the state, and we won't do any of that economic analysis because that's definitely one thing that John and I are not qualified for. But the stakeholders, basically that stakeholder group, when they see the results of the analysis, they will determine what the recommendations will be. And I don't know whether or not they will suggest or recommend that they be funded. But obviously, many of the recommendations may or may not require a certain level of state funding. And if so, then I imagine they might come to the conclusion that it could be funded from revenue. But it's up to that group, and I don't know what the cost estimate of that would be.
I'm just wondering when recommendations will be made and sort of what the next steps are.
Sure. So we're really hoping to get the final document posted in January, hopefully in the beginning of January. The next month, we're going to be doing the step where we apply the LIT to the prevalence rates here in Vermont. And then the next December, the month of December, will be used to have the stakeholders develop their recommendations and their final recommendations. We will be building, and we are building the report as we go. So hopefully that finalization process of the report will be quick and it'll be up in January, because the idea of this health impact assessment is to help inform legislative process, which obviously starts in January.
If I could I'll just add one more thing. So this session is hosted by the Vermont Public Health Association, which is not part of the health department, but we're a nonprofit independent entity. And we will be looking towards that product as well to develop our own set of recommendations that are using that science, but may not be the recommendations of these full broader stakeholders.
So thank you, Shayla and John, for this presentation. I just wondered if there will be enough, if your information has any degree of granular detail on the mode of ingestion in terms of being able to formulate any kind of recommendations for policymakers.
The research on edibles, particularly, it's very limited. There is some, and there's a lot actually that's being generated in Colorado right now. So we do now have potency equivalencies, which is a breakthrough in the research. So we now can actually say what the equivalent to smoking a joint is when consuming an edible or using a tincture, et cetera, et cetera. And that was actually developed just this year in Colorado. So that will allow us to try to begin to create equivalencies. However, when we're looking at health effects, it's going to be very hard because most of the literature is on smoked marijuana, almost all of it. And so or it's assuming smoked marijuana. And so those two things do confound it. Again, that said, we are learning a lot from tobacco and from the vaporizers and the e-cigarettes, and we do now have an equivalency formula, so hopefully we can do something with that, but I don't know if we will be able to.
Thank you. I just have a question about the Holland model. So Holland has illegal marijuana, but decrim, and it controls to some extent the more cheaply or with more easily the ability to control advertising, Second Amendment rights, right? So I'm wondering if you have a category where you're looking at what happens when you tax it and you regulate it, but it remains illegal, but decrim, and what that would look like in Vermont.
I don't have an answer to that one, sorry. Because it is decriminalized in Vermont right now, we do have sort of emerging and new information about use in Vermont under decrim, because that was very recent, as well as information about individuals who have gone to jail or not gone to jail, and how much the Department of Public Safety in the state has gained in fines from decriminalized marijuana. So there's that information, but that's all I know. That's all I know about that. We can, though, Carrie might know more. So we have her contact information. We can email her.
Just where is that information available?
The Carrie's information?
No, what you just said, the information you have on.
Oh, that's publicly available.
Okay.
Yeah, I can give it to you.
Yeah.
Okay, I think maybe just one last question.
Do the states that have legalized have testing and labeling regulations, so there's a dosage or a potency disclosure to consumers?
Yes, and this one is really new. So the one I know the most about is Colorado, and they legalized without that, and quickly found that was a problem for public health there. And so they came up with it over, I believe, the last not very many months. And all of that is actually now available and online with how they came up with that. They had a lot of different study committees. They had a bunch of research that they financed. That's actually where the potency equivalency research comes from, is that process. And so they now have a limit of, and I don't want to get it wrong, but I think it's 10 milligrams per serving, and a maximum of 10 servings in a package. And they each have to be individually packaged within that larger bundle. And then the testing that is done on both the first product, so either the butter or the butane that they create to make the edible product, and then also on the product itself. And it has to be below 10%, or below 10 milligrams, not 10%, below 10 milligrams in each piece, and if it's not, then they have to throw it away. So it is getting pretty strict, and it's getting much more precise there, and definitely a lot of good lessons, and also a lot of really, if you're me, a lot of really cool research they did on how to fix that.
Shayla, I think that also illustrates the complexities of what we're doing.
Yeah, it's very.
So I'm going to grab that from you. And I want to thank you, Shayla, very much, and I want to thank everyone for coming. You will notice around the room that there are a number of us that have very fancy, very, very fancy badges. We get to have these fancy badges because we volunteer for the Vermont Public Health Association. We serve on the board of directors, and we will be leading our association in taking these findings and deliberating on it and determining what we think ought to be heard in the conversations about the health impacts of marijuana use as we move forward in our legislative session.